technique, and the surrogacy law in 2021, and the Act mark a milestone in India's efforts to regulate reproductive technology and protect all parties involved, from donors, surrogates to the children born through these methods. Thank you.
Thank you, Dr. Shweta. I think it has been informative for all the doctors who are present here that how we have to function in the view of the new ART law. We have fortunate we have this law right now, so that we don't have this request from foreigners asking for surrogacy. We will straightforward tell them the foreigners are not allowed to do surrogacy in India. That is very straightforward. About Indians, that she has mentioned OCI card holder can do it, and Indian couples can always do it. And the instructions she has written, she has narrated very well. If any question on this ART, discuss with her during the dinner time.
Okay, thank you, sir. I think now we move on to the last talk, that's by K D Nayar, sir, and that's on the very important guidelines which have been prepared under the leadership.
Already checked in, must have checked in the surrounding areas of this project. Supposed to be one of the best property in Nepali. The basic idea of this CME was titled as nurture, and the CME was started, or concept was started by me in 2024 with the idea of nurturing the young doctors, those who are just completing their fellowship, or those who have completed their practicing, or just beginners, or those who have put less number of years, so that they can be nurtured and they can carry the legacy of their IVF practices. That was the basic idea. So now this is our second edition of the nurture, and we sincerely thank you all. Some of the doctors here, they have already attended the first edition of the nurture. This is the second edition, including K D sir, and most of these, I say about 10-12 doctors are here who are attended the first. I'm sure you all will enjoy this evening and the scientific session especially, and we look forward for a wonderful collaboration with you all. And I have not taken the name of the company, rather we don't want to take it also. I just wanted to tell you that we strongly believe in scientific activities, promoting our products scientifically, and all products are standardized, and the best product, the best quality, many IVF chains have started using besides the standalone centers. The good news, the good thing I wanted to share with you all, post my retirement from Bharat Serums in 2020, January 1st week I joined in 2021. And it is 5 years I have completed here. These 5 years are a glorious years for the Samarth Life Sciences. And I took over a business of both the division put together, which was on 13.3 crores. Today we are on roughly touching around 100 crore business in a 5 years. And the basic idea was to convert it to 3x in 5 years. That was 3x sales of 13 crores in 5 years, but we have almost climbed to the 6x now. It's only because of your support and your trust and your belief in our products and the quality of our products. We have our own manufacturing facilities. All products are our own products. And at least in the last 5 years, I have not come across even a single complaint. There will be some complaints on the products because these are all biological products. But still, I am telling you, there is not even a single complaint on our products, whether it is HMG, whether it is FSH. Besides this, since I got a mic, I just wanted to share with you all. In a span of 5 years' time, we are number 3 ranked fertility company, and we have got around 5 awards in last 5 years' time. Our HMG is ranked number 3, and our HCG is ranked number 3. Number 1 is Bharat Serum, number 2 is Vita's, number 3 is Samarth Life Sciences. This is just for your information. Thank you so much. Hope you all will enjoy this evening. Post scientific session, we have a time to get together. Banquet is also there. I hand over the mic to Sir. Thank you, sir.
We were focused on 37 key questions we created, and the outcome was efficacy, safety, and patient-related outcome. Certain topics were beyond their scope, like including treatment-associated cost or health economics and consideration of IUI. These were outside the scope of this guideline. The people question were created, and we topic selection, formation of GDG, keyword selection, first virtual meeting, Pico tables, second virtual meeting, data search, relevance check, quality check, evidence table creation, data evidence profile, consensus or recommendation, and review and approval of the draft guideline was done in March 24, and thereafter it was sent for review, and we will release it in ASHRAE 24 in ASHRAE. The positive evidence was high, moderate to very low. These are the standard way you evaluate your evidence, and the strength of recommendation was also determined by the subjective evidence, the resource requirement for implementation, acceptability of key stakeholder, impact on health equity. So this is how you divide this recommendation: strongly recommended, conditionally recommended, conditionally not recommended, or strongly not recommended. So again, to show what is strongly recommended.
On the poor ovarian reserve.
ये वाला ही काम करेगा सर. This is an additional for the recording.
Good afternoon.
Good evening.
I am the last speaker, standing before you on the dinner. We are going to have a gala dinner after this. We had prepared this first Indian guideline on poor ovarian response. This was published in 24, and although it's written in Indian Fertility Society, but when I made these guidelines, we had included 4 or 5 consultants from ISAR also. There was Dr. Padma Rekha Jirge, Dr. Sumanna Gurunath, Dr. Sanjeeva Reddy. So all these people have contributed in these guidelines. What happened is, I am giving you a short history. In the Hyderabad Fertility 22, we called an expert meeting, and we wanted to go about the poor ovarian responder guidelines. A diverse group was created. They included both IVF specialists, the genetics, embryologists, and gynecologists, and even patient nursing were also included. This was the guidance development group. If you look, Dr. Shesh Kamal Sankara was our advisor methodology, because she has been busy, she has been involved in all the ASHRAE guidelines, so, and we wanted to prepare the guidelines as per the ASHRAE module. And she has been very kind to help us. And these are all the pictures of the guidelines development group. You can see so many of the people are from ISAR also, although it was named IFS because IFS took the initiative. The objective, scope, and key question is mentioned. We were focused on 37 key questions we created, and the outcome was efficacy, safety, and patient-related outcome. Certain topics were beyond their scope, like including treatment-associated cost or health economics and consideration of IUI. So these were outside the scope of this guideline. The PICO question was created, and we created keywords to conduct structured literature search from database including PubMed, Medline, Cochrane, Embase, Scopus, covering literature up to 31st October 2023. And the studies were classified as meta-analysis, randomized controlled trial, observational studies based on the study design. The systemic reviews and meta-analysis were evaluated by AMSTAR-2 tool, and the randomized controlled trial and core study was analyzed by GRADE tool. This is the PRISMA flow chart. We had identified 21,935 records were identified in this database. After the duplicates were removed, 5,826 were left. Record screen based on the titles and abstracts. The records which were excluded were mentioned here. We were left with 228. Full text articles were only assessed. The articles published, presented in conference, they were not included. So 116 full text articles were eligible, and they were reviewed by all these GDG members. This was our milestone. We started in 2022.
we did a topic selection, formation of GDG, keyword selection, first virtual meeting, PICO tables, second virtual meeting, literature search, relevance check, quality check, evidence table creation, grade evidence profile, consensus and recommendation, and review and approval of the draft guideline was done in March 24, and thereafter it was sent for review, and we released it in ASHRAE 24 in ASHRAE. The qualitative evidence was high, moderate, low, very low. These are the standard way you evaluate your evidence, and the strength of recommendation was also determined by the certainty of evidence, the research requirement for implementation, acceptability of key stakeholder, impact on health equity. So this is how you divide this recommendation: strongly recommended, conditionally not recommended, or strongly not recommended. So again, to show what is strongly recommended, the 4 stars are given. The test or intervention can be applied to most patients or those patient group for whom it may be of relevance. So it can be adopted as a policy in most situations, strongly recommended. The condition recommended is it can be applied after thorough discussion with a possible benefit and risk. Conditionally not recommended, this intervention should not be applied to patient at this stage, but it can change later on when you have more evidence. Strongly not recommended, based on the study or lack of efficacy or lack of biological rationale, this intervention should not be applied to the patient. So March 24 we had the draft guidelines, then we had a stakeholder review between February to May 24, and these were the stakeholders who reviewed our guidelines. If you see the list, you have past editor of Reproductive Biomedicine, Geddes, and Rishika Pai. Jens Trevor was from British Fertility Society, Linda Goodis was from American Society of Reproductive Medicine, Nandita Pashetkar, Raj Mathur is also from British Fertility, and Yin Chong is from ASHRAE. She is the coordinator of SIG Reproductive Endocrinology. And we have a host of other stakeholders, external guideline review by Alberto Verrilli, Ava Maheshwari, Barry Setta. They sent us the comment and we worked out with the comment, and some of the comments we adopted in our guideline and some of the comments we gave them the answer. The review and approval of guideline was done in May, and June 24 it was released in Amsterdam, and this was the release picture where Sheikh Sankara and all other guidance development people, we released the guideline. And this guideline has been published in IFFS Journal, Global Reproductive Health. It has been published on 8 September 25. This is the first Indian guideline which has been published in a index journal. And the same guidelines with some changes, we also sent it to our own journal, Fertility, Sterility and Research. It has also been accepted. It is under publication. These are the recommendations that from 37 PICO questions, we gave 45 recommendations. I am not going to go into the details of recommendation. I will just discuss few points where there has been confusion till now. So the use of AMH as a biomarker, assessment of enterofollicular count, all these are strong recommendations. And intervention which is not recommended for POR is the routine genetic polymorphism, routine pre-treatment estrogen in luteal phase. This is conditional. And oral contraceptive pill is not recommended, strongly not recommended. Use of gonadotropin releasing hormone antagonist, delayed start is also conditional. Pre-treatment antioxidant for poor responders is conditional. Routine treatment with estrogen in luteal phase is not recommended. It is a conditional recommendation, and there is considerable variability between study with regard to definition of poor responder. So that is why we think it is still conditional, but many of the units are practicing this practice of giving luteal phase estrogen. So further research is recommended in cases of where there is insufficient evidence, like insufficient evidence to make a recommendation for routine immunological testing or for alternative medicine therapy. All this is strongly not recommended. The evidence-based recommendation for clinical practice in ovarian stimulation, antagonist protocol and agonist protocol are strongly recommended. Mild stimulation with low dose gonadotropin strongly recommended. Mild stimulation with oral letrozole in combination with low dose gonadotropin is strongly recommended. Mild stimulation with clomiphene also strongly recommended. The decision to use clomiphene citrate alone as a mild stimulation protocol in oral poor responder, this is a good practice point. There is no scientific evidence for this. Intervention not recommended. Again, agonist player protocol is not strongly not recommended. Dual stimulation is not recommended. I discussed about this. The luteal phase stimulation is not recommended strongly. Modified natural cycle is strongly not recommended. Progesterone prime ovarian stimulation is also not recommended. The short GnRH agonist protocol is not recommended over antagonist. It is a conditional. The dual stimulation, most of us think these days that probably dual stimulation is a answer to poor responder. The dual stimulation may yield additional oocyte and higher number of viable embryos for transfer besides reducing the dropout compared to conventional stimulation, but it does not improve the ongoing pregnancy rate or live birth rate when compared to conventional stimulation. And the data on the cost effectiveness for increased cost of gonadotropin in the same cycle, and you have to freeze the embryos, thought that all this increases the cost. That is why it is strongly not recommended. Although we had stakeholder reviews, they did not agree with this recommendation. So therapeutic management in women with a diminished ovarian reserve, a systemic review, it was published in Fertility, Carlo Galveghi, and they say that probably it can be better if you can give a dual stimulation. Alberto Borrelli also wrote to us that dual stimulation can be considered, but we answered him that in view of the review of RCTs comparing dual stimulation with conventional antagonist protocol, we need to have robust evidence to support the clinical decision. And that is important, that we cannot just blindly give any protocol. We must have a robust evidence for the clinical decision, and at the time of this guideline, the clinical robust evidence was still lacking. And due to the absence of RCT comparing dual stimulation with two consecutive conventional stimulation in the same patient with a mandatory postponement of embryo transfer, dual stimulation is not recommended in poor responder. That was our recommendation. By stimulation, you are giving two stimulation type, one after the other. Does it improve? Does any benefit? And based on the number of total and mature oocyte retrieved in women with poor ovarian responder, there seems to be no benefit of dual stimulation versus two consecutive antagonist cycle. Double versus single stimulation in young poor responder followed by fresh embryo transfer in randomized control trial. This was published by Polizos. What he did a luteal phase stimulation followed by follicular phase stimulation, the other way around. And he said that although dual stimulation number of embryo blastocysts are more compared to single stimulation, the decision of performing dual stimulation should be evaluated with caution. The progesterone prime ovarian stimulation is also strongly not recommended, because when you are giving progesterone prime ovarian stimulation, you have to again freeze the embryos, and that increases the cost, and it doesn't improve the live birth rate. That is why it is not accepted as a protocol. Evidence-based recommendation for clinical practice, use of either HMG or FHS can be strongly recommended. Mid-follicular addition HMG is also conditionally recommended. Earlier mid-follicular initiation recombinant LH is also equally recommended. This is all, both of them are conditional. Choreofollicular alpha and choreofollicular alpha and HMG are equally recommended. These are strongly recommended. These intervention not recommended in pure ovarian responder. Use of urinary